sometimes this is tenaculum, which you have seen holding the myoma. So it can bite the myoma, because myoma screw cannot be articulating, because screw is straight. So they are making tenaculum, so that you can take a deep bite and then you can manipulate it for the myomectomy. Then you have the different type of atraumatic intestinal clamps, which can use to hold the small bowel, and it can give you the very good articulation, and you can catch it, you can rotate it, and you can work for those purposes. You have the clip applicators, hemolock applicators. This is hemolock applicators, which can be used for uterine artery, splenic artery, renal artery, cystic artery. And just like how we do in the laparoscopy, you can apply the plastic hemolocks. Hemolock is applied by the assistant, and then he will load it, and then you can use for the different surgery. So these are the instruments. Now I am going to discuss about the drapings. These are the disposable drapings which comes for the robot, because robot itself, surgeons, this patient side card or robotic arm cannot be sterilized. Just like we cannot sterilize our own body. So what we are doing? We are wearing a gown, a sterile gown. We are covering ourselves with the gown. Same way you have to use a sterile gown, and for that you have the different disposable gowns available by the intensive surgical. But it is expensive. One is costing you $100. So these are coming in the packs of these, and these are wrapped and gamma ray sterile in a way that just you unwrap it and you can open it, and you can put it and you can apply the sleeve. So these gowns are impermeable. It is made up of plastic. Sometimes we make it like that, but it is not good, because we autoclave it with the gown aprons and we use it. But it has one drawback, that these are the Indian gowns, which is autoclave with our apron, and you can wear it like that. But it has a problem that it is permeable with the water. So it can, if it is wet, it can take the infection. But these are made up of high quality polypropylene. So this is also one extra cost involved in the surgery, and you have to be careful. And you need to buy every time. Once you do the surgery, you have to put a drap over the robotic arm, and then it will be completely sterile. Now I am going to demonstrate you the different methods of handling the robotic arm. So this is called as central column. Central column is, you can understand, like a vertebral column of the robot, where it stands. And you have a setup joint 1, setup joint 2, and it has a 4-arm. This is arm number 1, arm number 2, arm number 3, and it has, this is not considered as an arm, because this is the optical arm. Optical arm is the center arm, which is not considered as a real arm, because it is only for telescope. And working arms, there are 3 arms. This is arm number 1, arm number 2, arm number 3. It is written there also. If you see, it is written, this is number 1. And it has a different buttons. These are the buttons, and this is also button. So you can rotate it and you can lock it like that, and these buttons, it can go up, it can do. This is button setup joint 1. Setup joint 1 will use to move it from here. And ideally, the angle between the setup joint 1 and setup joint 2 should be 90 degrees. Just like when you are holding it like that, your angle between your arm and forearm should be 90 degrees. And just by pressing this button, you can control it. It can move up, it can go down. Why it is required? You don't have to do during surgery, but at a time of docking it is required. Docking is a procedure in which the robot is attached with the cannula of the patient. Trocard you will put yourself, and once the cannula is in the position, for docking you have to press these joints. And if you press it, it will start blinking. Once it is blinking, that means it is in control of the assistant. When you leave it, it is locked. Then it will not blink. If it is not blinking, that means it is in the control of surgeon. So this is to control the setup joint 1. And this is to control these arms. If you want to bring it up, down, you want to rotate, right, left, then you will use this button. This button can be used 2 ways. Either you press it and leave it, or you press and do, and just you do like that. So it will start blinking. Once it is blinking, that means it is control of your movement. During surgery, this movement is spontaneous. That will be taking the command from the console of the surgeon. But during the docking, you have to keep it pressed so that you can move it. And as suppose you are moving, suppose this is my cannula. I want to dock in this cannula, then I will press it and I will bring it here. And then angle I will adjust and I will dock. And then I will clip it. It is attached now. My thumb is attached with the robotic arm, exactly same way. This you have to do, after that you have to forget it. You don't have to do anything. In my opinion, robot has 4 arms and 4 additional arms. Do you know why? Robot is not only holding the instrument, it is also holding the cannula. So just like sometime in laparoscopy when you have to take the cannula out, what you are instrument out, and if instrument is tight over the cannula, what you are doing? You are holding with the one hand cannula, on the other hand you are pulling it. Otherwise, cannula also comes out. But in robotic, this is big advantage that cannula cannot come out anytime because robot is always fixing the cannula and keeping it in the position. So whatever instrument will go in and out, this movement of the instrument will not affect the movement of the cannula. So actually that way if you will consider robot has 8 arms because it is holding the cannula with one arm, another one it is going in and out and always maintain the remote sensor in the position. So this remote sensor will never come out or go in once it is fixed at one place. But in laparoscopic surgery, this is our continuous struggle because repeatedly sometime our cannula comes preperitoneal, sometimes goes very deeper, sometimes cannula is so deep that we cannot bring the tip of the instrument out of the cannula. Instrument tip is hiding into the cannula, especially in a small space. But these problems will not be in the robotic because once the remote sensor is in the position, it doesn't come out and doesn't go in. And there is a zero movement at this remote sensor. It won't move at that time. Even if suppose patient is sleeping in the table or patient is moving, if the pressure is exerted on this remote sensor, it will give you error message that arm number 4 is obstructed and it has a problem with the movement. So in those situations, your assistant will just press this setup joint and bring to make it neutral position so that it will adjust. So once you will fix it, these things will take care. Robot itself has its sensing capacity to prevent the complication. Otherwise, it's a metal. It can tear the abdomen. So that's why this remote sensing technology is important. Now, you have to take care that in the optical arm, there is an optical arm. In this optical arm, there is one sweet spot. So this optical arm is for telescope to attach, and it should maintain a coaxial alignment. That is, angle between the arm, central column, and the setup joint should be in the same axis, so that when you perform the surgery, you will not have the problem with the arm. And you should take care that this spot, this blue area, there is one arrow here. If you will see, this is a blue arrow, and there is one blue strip. This arrow should be in the blue strip here. That means it is good. If it is outside the blue strip, suppose if it is like that, that means it is wrong. So it is not a coaxial alignment, and then there will be a problem. So always keep it in the same axis like that, and this should be the blue, so that this joint and the central column should be in the same axis, and the instrument will be from the other side, so that a 90-degree manipulation angle will form and the collateral alignment will be there, and telescope should be in the center of the working instrument. So contralateral port position is required, and baseball diamond concept of the port position will be applicable in the Da Vinci robotic surgery. Now once you have attached it, then you will switch it on, and after switching it on, you have to do homing. Homing is a phenomenon in which robot will do its own checkup that it is fixed all around. Just like when you go to do some exercise, first you are doing warming up. So you are warming your body and then you see that everything is fine. Exactly same way in the surgeon console, you have to press one home button. Dr. Chauhan is pressing the home button and you will see it will check its own. it will check and it will see that everything is fine. And you will see here it is writing also that prepare the master and do for homing. So all the task is already programmed. So robot itself will tell you that what is the next task. So Dr. Chan is now pressing the homing button and you will see this arm will move. And master console arm also moves. So now it is pressed and see here it is moving up, down and it will check and then that also is moving. And that is checking the all the arm and it is checking it that there is no any obstruction. All the movements are clear and during that homing process it will check the software, it will check the joints and now it is ready. Now it is saying that ready, prepare the patient for surgery. Now once the patient is not in the table, you can move the arm also. You have a button behind and if you press it, arm can move ahead, arm can go from one to another and entire robotic arm can go from patient side cart can go from one place to another. On the bottom there are two buttons, one is drive position, another is neutral position. And you can see now the robot is moving. But you will not bring the robot pushing back. Now robot cannot move, you should not bring the robot near the patient once the patient is not anesthetized, otherwise he will be afraid seeing it. So first anesthetize the patient, then you put the trocar and then you will bring the robot. Once you have done the homing, after that you have to do in the optical part some management. So I am going to demonstrate you how you do in the optics. In the optics you have to do white balancing, focusing and the calibration, just like how you do laparoscopy. Basic principle of optics, basic principle of the energy sources, the bipolar, the monopolar, the harmonic, the tissue response generator, those all principles are same as laparoscopy. Here also in the camera you have the aperture, you have a fibroscope filter, shutter speed, window, all is same as laparoscopy. Only difference is that in laparoscopy it is monocular